Hello, Mr. Turner.
Yes.
Hi, my name is Ashley. I'm a student nurse practitioner. How are you doing today?
Doing good.
Good. So today I will be examining your chest, lungs, and heart. Do you have any questions before I get started?
No.
No? Okay, so the first thing I'm going to do is pull your gown down to expose your chest for some inspection. So your posture is upright, you're not leaning forward in a tripod position, you're not experiencing respiratory distress. Your skin color is appropriate for an African American male. There's no signs of cyanosis, which would be bluish, purplish discoloration of your lips or even your fingers. So the next thing I'm going to do is go over some anatomic landmarks. Starting with your trachea, I'm going to inspect and palpate. So your trachea is midline. I'm just going to palpate it. All right, no deviations, any pain or tenderness?
No.
Okay. I'm going to work my way down to this suprasternal notch. So this is a depression in between your clavicles. And then I'm going to continue to work my way down to the angle of Louis. So this is an articulation on your sternum. This is a good landmark to know because this is where your second rib is connected to the sternum. So this is a good place to start if you need to count, say, ribs or intercostal spaces. The next thing I'm going to look is your anterior, posterior to lateral diameter. So your anterior, posterior is about a 1, and then lateral is about a 2, so a ratio of 1 to 2, which is normal. Patients with a barrel chest tend to have a ratio of 1 to 1, and that's typically seen in patients with COPD. I'm just going to look and palpate your ribs. So your ribs are not prominent, but if I palpate them, you can feel them and they are downward slope. So your chest movement has been symmetrical, you're not using any accessory muscles, your respiratory pattern is unlabored, it's regular, it's relaxed. I have not heard any audible lung noises coming from your breathing, such as like rhonchi or wheezing, and your respiratory rate has been 16 breaths per minute. The next thing I'm going to do is palpate the front of your chest. Your skin is warm. I'm also palpating for crepitus, which is like a crackly, bubbly feeling, which would indicate air in the subcutaneous tissue. Do not hear any. So I'm going to have you swing your legs around and I'm going to see your back. First I'm going to do is palpate your back along your vertebrae. You let me know if you have any pain or tenderness. Any pain, any tenderness?
No.
Okay. All right, next I'm going to check for your thoracic expansion. So I'm just going to put my hands on your back, pinch some skin in, and I'm going to have you take a deep breath in and out. And one more time. So you have equal and symmetrical chest expansion. My thumbs moved in and out as you took your breath. The next thing I'm going to do is palpate for tactile fremitus, which I'm going to use the ulnar surface of my hands. I'm going to place them in different positions on your back and on your side. And I'm just going to have you say 99 every time I move my hands, okay?
Okay.
So this is just testing for vibration because vibration can be heard through lung tissue. So when I put my hands on, say 99.
99. 99. 99. 99. 99.
And lift your hands up.
99. 99.
Your tactile fremitus was symmetrical, vibration was felt symmetrically bilaterally. The next thing I'm going to do is percussion along your back, so I'm just going to be kind of tapping on your back, okay?
Okay.
Okay, very good. So your percussion, you have resonant and symmetrical percussion tones. The next thing I'm going to do is diaphragmatic excursion, which is another percussion technique that I'm going to use. So I'm going to percuss along your back again, but this time I'm going to have you take a deep breath in and hold it, and then I'm going to mark your skin where I hear the sounds go from resonant to dull, okay?
Okay.
So whenever you're ready, I'm going to have you take a deep breath in and hold it. Okay, hold it. Okay. Okay. And now I'm going to have you hold the exhale. So I'm going to have you breathe, take a breath, and then hold your exhale. I'm going to start from the bottom and work my way up, okay?
Okay.
All right, whenever you're ready. Okay, and hold that. Okay, you can breathe normal. And I'm going to do the same thing on the other side. I'm going to start from the top and work my way down. I'm going to have you hold that inhale, okay?
Okay.
Whenever you're ready. Okay, breathe normal. And then I'm going to start from this bottom mark and work my way up. And I'm going to have you hold that exhale, okay? Whenever you are ready. Okay, you can breathe normal. So now what I'm going to do is bring out my measuring tool and measure the distance between these in centimeters. So this is 4 centimeters, and that is also 4 centimeters. So your excursion distance is 4 centimeters, which is normal, because normal is 3 to 5. The next thing I'm going to do is listen to breath sounds. I'll start on the back, because that's the way you're facing, but I will listen laterally and anteriorly. So I'm just going to have you take deep breaths, okay?
Okay.
Go ahead. Alright, very good. I am going to have you turn around and face the front. And I'll listen on the front side and a little bit on the sides too. Deep breaths. All right, very good. You have clear vesicular lung sounds. No adventitious lung sounds were heard, so such as no crackling, no wheezing, no rhonchi. So now I am going to listen for vocal resonance. I am going to do this on your back, so if you don't mind just swinging your legs one more time for me. I'm going to place my stethoscope in a bunch of different spots on your back, and every time I move my stethoscope, I want you to say 1, 2, 3, okay?
Okay.
All right, whenever you're ready.
1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3.
All right, so there was no increase or decrease in your vocal resonance. So that concludes the chest and lungs. Now I'm going to begin the cardiac assessment. So I'm also going to start with inspection and noting some anatomic landmarks. Noting first will be the sternum, which is right here. Then we're going to do your sternal borders. So you have your left sternal border, and then you have your right sternal border, and then we have the apex of the heart. So the apex of the heart is the base of the heart. So it is at the 5th intercostal space. at the left mid-clavicular line. At this point, that's where your point of maximal impulse is. Next, I'm just going to inspect your precordium, which is just around your chest. I'm looking for heaves, lifts, or pulsations. I'm looking at a bunch of different valve locations that I will be verbalizing here shortly, but I'm just going to look in a bunch of different locations. And I'm not seeing, I see no heaves, no lifts, I see no pulsations. I am going to shine my light at your apical impulse just to see if it's visible. It's not uncommon for it not to be. I'm just going to look to see if I can see any pulsation there. Which I don't, which is normal, like I said, and I will palpate for that. So the next thing I'm going to do is palpate at the valve locations for thrills, okay? So, aortic, pulmonic, Erb's point, tricuspid, and then mitral. So the mitral valve is where your apical pulse is. It should be palpable, and I am palpating it right now. I feel it. Okay. Sometimes you can lay a patient on their left side to feel for this pulse. Just for this situation right now, we don't have you're not laying in a bed, we can't really recline you, so I'm just gonna feel for it while you're sitting up. So yeah, I felt no thrills, and your apical impulse is palpable. Next thing I'm going to do is use the diaphragm of my stethoscope, and I'm going to listen for heart sounds at all the same exact locations, okay? Aortic, just the second intercostal space, right sternal border. Pulmonic, second intercostal space, left sternal border. Erb's point, third intercostal space, left sternal border. Tricuspid, fourth intercostal space, left sternal border. And then the mitral, fifth intercostal space, left mid-clavicular line. So your S1 and S2 is normal. Down here, your S1 is heard the loudest at your mitral valve. And then I'm come back up to the pulmonic because this is where your S2 is heard the loudest. Your rhythm is regular, like I said, S1, S2, both can be heard. There's no S3 or S4. S3 is common in patients that are fluid volume overloaded. Here, no split heart tones either. So the next thing, no asynchrony within your heart. I am going to now use my stethoscope again, but use the bell and listen for any heart murmurs. I'm going to listen at all the same spots at all the valves one more time. Aortic, pulmonic, Erb's point, tricuspid, and then mitral. So no murmurs were heard. And that concludes my exam. Thank you very much, Mr. Turner. You have a good day.
Thank you, you too.